thank you everyone for being here on this unseasonably hot day. Although you know what, with a hot and a humid day, your eyes are going to be less dry in general. So that's something nice because dry eye, after all, is a very common problem. And although that's not the topic of what I'm going to be talking to you about, it's probably the most common cause of intermittent blurry vision, much more so than glaucoma. But that doesn't mean that glaucoma is not important. In fact, glaucoma is still the number one cause of irreversible blindness within the US. So let's talk about this. And I have structured this talk in in a way that kind of helps you to build some understanding about glaucoma and go through the treatment options. And finally, what are some of the sort of the common questions that people have for glaucoma? So I've summarized it in 9 or 10 questions, and here are the questions. First, we start out with what is glaucoma, what causes it, and how is it diagnosed, and what is considered a normal eye pressure, and how is glaucoma treated, and also the very common question, why is my vision worsening when my eye doctors kept telling me that everything looks okay? This is more like a philosophical questions rather than an actual medical question, although I think it is quite helpful to understand how most doctors think so that you know kind of how to interpret what they're saying. And that has more to do with psychology than that has to do with anything more medical. So we'll get to that. And then finally, are there supplements, diets, or exercises that can help? I'll touch on some of the latest evidence or lack thereof on that. And am I going to go blind when I'm told that I have glaucoma? That's a question I'll answer. And finally, what's coming down the pipeline in the research area? And there are so many research sub areas that unless you're in the field, it's very hard to kind of keep track with of all the progress and make sense of what is potentially uh, something applicable versus just hype. So I'll do my best to kind of give you a very quick summary. So hopefully by the end of the night, you'll feel like you have a more solid grasp of what glaucoma is and what glaucoma isn't, and what do you need to do about it if you have that diagnosis. So let's start with the basics. What is glaucoma? Here is the textbook definition. A chronic condition in which the optic nerve loses its volume and function, most commonly due to its ability to cope with the pressure within the eyeball. So don't worry if this statement sounds confusing. Let me give you sort of the everyday common explanation that I give for glaucoma. It's basically a chronic degenerating condition coming from the fact that your nerve, your optic nerve, which is this cable that connects your eyeball to the brain, that nerve is having trouble coping with the pressure in the eye. And as time goes on, this pressure damage leads to uh, a number of characteristic findings that we can often see on test. And that is what defines glaucoma. The type of vision loss that we almost always see in glaucoma starts out in the periphery of your vision, and slowly it starts to creep towards the center. Some of you may have heard that glaucoma is called the silent killer. The reason it's called the silent killer is because it's pretty much clinically silent, meaning it doesn't give you symptoms until relatively late in that process. So when you think that your vision is getting worse, it's getting blurrier, you have some pain here and there, I can tell you probably 90 to 95% of the time, this is not glaucoma. Maybe even higher probability that that's not glaucoma. Because most forms of glaucoma do not give you any noticeable symptoms. Things happen very slowly. If you're one of my patients and looking down on that list, there are quite a few names that I recognize. You may have heard me saying, imagine all your optic nerves are like individual light bulbs at the Costco warehouse. If inside of the Costco there is kind of this pressure situation in which the air pressure is so high, it's starting to kill off the light bulb one by one. Initially, you're not going to notice that the entire Costco warehouse just loses one light bulb at the ceiling. But if that process keeps happening, after, like, let's say the ceiling will lose one light bulb an hour, maybe a few days into that process, you're gonna start notice, things are feeling a little darker. And that's usually when people realize something is going on. But that doesn't mean that the problem starts then. The problem actually started way earlier. And there is that huge clinically silent period that glaucoma often doesn't get diagnosed until it starts manifesting itself either to the patient or becomes very evident on the test results. So anyway, that's sort of the typical progressions of glaucoma. So here is an illustration. Here's a normal vision where you see the two cute kids. But for people with glaucoma, you simply don't see the side very well. When you look straight ahead, you can still see the image, but you will not be able to see the difference between this image and that image. You cannot see the tiny little table that's behind these two kids. Okay, a table, not a little wall. The structure that within which the kids stand, you cannot see that structure. But that's not very easy to register that as something abnormal because to see that you simply need to look, turn your eyes a little away, then you can see it. So most people don't see that as something uh, necessarily wrong, and therefore that also kind of delay the diagnosis quite a bit. So what causes glaucoma in general? The spotlight often focuses on eye pressure, but that doesn't mean that the eye pressure is the only cause that that leads to glaucoma. However, eye pressure is the only thing that is treatable from all the possible things that can cause glaucoma. I won't go into the eye pressure unrelated cause for glaucoma, but just to entertain um, your curiosity, these other huge lists of things that can potentially cause glaucoma may even include things like your central nervous system pressure, meaning your spinal fluid pressure, which you really don't have much control either. And there's no pharmacologic treatment to regulate the cerebral spinal fluid pressure. There is something surgical to modulate that, but that's you certainly don't want to have your spinal tap being done on a daily basis just to normalize that pressure. There's also other things like your ocular perfusion pressure, your blood pressure, your blood vessel health that supplies the tissues around your eyeball. These are some of the things that we know can lead to glaucoma-like findings that are independent of your eye pressure. In other words, your eye pressure can be normal or even low, and yet your loss of peripheral vision continues. And very often that's because there are these other non-pressure related phenomenon that's going on. And those are really difficult to treat simply because usually they involve areas of often the brain that are just not reachable, whether pharmacologically or surgically. Or in order to modulate those things, the risk is too high that neurosurgeons often we need to involve their help simply don't think that it's worth the rewards to go after some of those targets. So what other things can cause the pressure to kind of go up over time and lead to glaucoma in some individuals? Think of glaucoma or eye pressure pretty much like a plumbing problem. And like a plumbing problem, usually there's something physical. So the size, the density, and the porosity of your natural drainage system within the eyeball comes in all varieties. There are people with a larger size drainage pipes. There are people with very dense and very porous drainage pipe. And there are those that don't have as porous or as dense or as large of a drainage pipes inside of their eye. I'm not talking about your tear drainage. Your tears are external to the eyeball. I'm talking something that's inside of your eyeball. So think of your eyeball as like a basketball. Your tears are like the water that you use to wash the basketball. But I'm talking about the fluid that's sitting inside of that basketball. And that's what gives rise to the basketball's pressure, the internal pressure. So, so your eyeball has an internal pressure, and part of that pressure is determined by how much fluid is being produced by the eyeball and how much fluid is being drained away by the eyeball. So it's the draining process that's very different from person to person, and the genetic variability of that kind of underpins why some people are more susceptible to pressure problem than others. And I had highlighted in red here that genetics has a lot to do with it, but not in the way that most people think. Doesn't mean that because your parents have it, then you're doomed to have it. And also, just because your parents don't have it, it doesn't also doesn't mean that you will not have it. Because like most things in medicine or most things that have multiple causes, it's not either or. A lot of times it's how much risk factors you have and how close to the edge you have. And that determines it. So it's not a if either you have it or you don't. And just because one has it, then you're bound to have it. It's not as simple as that because it's polygenic, meaning there are multiple foci or loci along your DNA that, if they all kind of if multiple genetic products all contribute to glaucoma and you have them all, then you're in the bad shape. But if you have some but not all, then it depends on how much and whether both of your parents have it or not. So that process is a little complicated. So it's not linear at all. In addition to what you were born with, trauma or chronic steroid use or previous eye surgeries, uncontrolled diabetes, and I had to highlight the uncontrolled part. Just because you had diabetes does not mean that you're going to have glaucoma. But if you have uncontrolled diabetes for months and for years, then your odds of getting glaucoma are starting to go up. It doesn't go up overnight. Again, few things in life just because you make one bad mark doesn't mean that you're doomed to have something. But if you keep having the same problem over and over and over, then if eventually your system is gonna give out, your eye pressure may start to go up. But it's rare for that to happen just because you have one night of really high sugar after eating a lot of ice cream. It just means that you're gonna have a high sugar, but it doesn't mean that you have diabetes. But if you have bad diabetes for several weeks, several months, or even several years, then your odds start to go up. Very low blood pressure. This may be counterintuitive, but think of your blood pressure and your eye pressure as mostly two separate kind of pressure system. They do kind of affect one another. I won't go into the intricacies of that. That's a whole lecture by itself. But just know that if you have high blood pressure, then you are at a higher risk of getting cardiovascular diseases. Having cardiovascular diseases is a risk factor for getting glaucoma. So there is a little indirect relationship here. However, if you have low blood pressure, then you simply don't have enough blood flow to your head. And what is in your head? Your eyeballs. And your optic nerve is also just right behind your eyeball. So if your optic nerve is not getting enough blood flow, guess what's going to happen? It's going to atrophy, meaning it's not going to do well. It's like a flower that doesn't get enough water, or you don't put enough of certain nutrients in the soil. It's not going to bloom. It's going to just look sick. And so that often can lead to glaucoma, independent of the eye pressure. So these are some of the other things that can give rise to glaucoma. So I just want you to kind of appreciate the multiple sort of players that can come into this glaucoma picture here. Now, how is glaucoma diagnosed? And of course, we look at the eye pressure because that's one factor we look at. Again, this is not the only thing that we look at. So I often tell my patients, don't overanalyze this number. It's just a number, but we have to interpret that in the context of what's going on in other parts of the eye. Of course, I had to do a comprehensive eye exam, looking from the front to the back, anatomy. I focus a lot on how the optic nerve looks. Your optic nerve is like your GPA. It tells me a lot of information about what has happened recently. I may not be able to tell you when something happened, but I can tell you if it has taken a hit or not, especially if the damage is looking very obvious. And I can spot an obvious glaucoma damage even if you don't think anything is wrong, because glaucoma, again, can be clinically silent for long periods of time before the patient himself or herself becomes aware. And also function. This is a very important one. Anatomy, meaning the way the optic nerve looks, most surgeons have come to appreciate how sort of the variety of optic nerves that we can come across. There is really, it's hard to define a quote unquote normal look of what glaucoma nerves look like. In fact, multiple scholars and clinicians and scientists have tried to train artificial intelligence to recognize normal versus abnormal optic nerve. And no humans and no AI systems have been able to do that consistently. That's because there's so much overlap between normal and abnormal that oftentimes, if you try to draw an artificial line in between normal and abnormal, you end up overdiagnosing some people and underdiagnosing some other people by using the same algorithm. So it's not so much as looking at it, although looking at it kind of gives us some information. What we are looking at is you had to couple that anatomical information with functional information. An optic nerve can look very thin, can look like it has been damaged, and yet the functional test shows that it's functioning fully. So we do the function test by having the patient take a peripheral vision test. Okay, not a central vision test. Your central vision test is just how good your vision is, 20/20, 20/40, 2100, or whatever. Your peripheral vision is to see how far out you can see on your periphery. Some of you may be thinking your peripheral vision is perfect. Well, that's what you think. Okay, we often have to separate what you think and what your opinion about what is going on versus what is going on in reality, right? A peripheral vision test is a test where the computer actually isolates individual point and tests you multiple times to see how reliable you are and give a final score. And often the results can be quite surprising. People who think they did poorly ended up doing actually really well. People who thought they did really well, and actually the peripheral vision test may show a little defect that they're never aware of. So we've seen enough of that to say that the best thing to do is just go through and take that test, and then we can, go through the test results. Now, the final line here that I highlight in red is changes over time. It's very important to, if we see something suspicious, sometimes I myself, I can speak for myself. Uh, I don't necessarily, just because I see a nerve that doesn't look normal and a functional peripheral vision test that doesn't look quite normal, just because of that, I just start somebody on drug because I'm not sure how long has it been that way. Maybe the nerve has always been looking like that. Maybe this is a congenital defect, meaning the person was born with this. So how do I know is it something that I need to treat versus something I can watch? I often just repeat the same test in 6 months or in a year. And if things look the same, then we don't need to treat something that has been there and that's stable. A parallel analogy would be an incidental little nodule that your pulmonologist finds on your chest CT scan, measure 1.5 centimeter. The pulmonologist doesn't know what it is. All it can tell you is it seems calcified. It has a pretty distinct border. Well, I don't know if that's cancer, but it's kind of borderline size, and let's just, watch it very carefully, repeat the scan in 6 months, in a year. If it grows, then we may have a problem. If it doesn't grow, it's always there. Maybe it's always there. So that kind of mentality applies to glaucoma as well. When in doubt, repeat the test, see if it's changing, if it's worsening, and then taking all the evidence together come up with the sort of a diagnosis. Are we in need of more pressure reductions, or this is we're just kind of watching history unfolding here? So here is an example of a peripheral vision test, and that's the machine, the little circle area there, that's where you rest your chin, and you're supposed to look straight ahead. So many of you may have, will definitely have taken this before. Another important test that we often do in a glaucoma clinic is called optic nerve picture. And this particular test measures the total thickness of your optic nerve. So it's a very quantitative test. We follow the optic nerve thickness because it gives us anatomical information, whether your optic nerve keeps getting thinner. So think of that using our earlier Costco lights analogy as it's counting the number of lights that are still on. In a simplistic sense, that's what this test is. However, I would also avoid overanalyzing every single number on this test. I know there are, definitely some very quantitative data-driven individuals out there, maybe in the audience tonight. I would just say that this test right here doesn't matter if you get it from Zeiss or Heidelberg, which is another is a German. Actually, they're both German companies. Uh, these two tests are prone to motion artifact, meaning if your eye simply just moves a little bit, it'll give you a very different set of number. So we don't look at individual number insofar as we look at overall trend. So think of this as like taking measuring your weight. Throughout the day, your weight can fluctuate and depends on the different scale you use. It can fluctuate, depends on the amount of clothes that even the floor on which you put your scale on can influence the final readout. So of course you can fool yourself into thinking, oh, I lost my weight if you just strip down naked and just use the bathroom to really empty yourself out, and then you can celebrate, yay, I lost some weight. Or you can, artificially drink a lot of water, put on heavy clothes and time of the day and so on and so forth. So this process is kind of like that. And that's why a lot of time in glaucoma clinic, we're running a test, not because I'm looking for a particular number, but it helps to add to the overall data where your historical numbers tend to be. So if we do a trend analysis, we can spot the outlier or we can spot the trend. Whether you're always kind of slowly losing your nerve or you're always kind of just ranging around a certain set of number. So what is a normal eye pressure? It's, when I look into somebody's eye or anybody looking into anybody's eye, there's not going to be a line that says this particular eye can only tolerate pressure up to certain PSI, like the tire. If nature makes it that way, that would have been a lot better. But the thing is, we don't know. And also, as you get older, your eyeball will tolerate different amount of pressure. So this is not a set point where you have to be in a certain zone. However, we do know what the population range for the eye pressure is. It tends to sit around 7 to 22. So if you're 7, that's great. You're just on the lower range of normal. If you're 22, it just means that you're on the higher end of normal. All else being equal, is not by itself something to be alarmed about. Just like it's fine that you are 4 foot 10 as an adult, it's also fine that you're 6 foot 10 as an adult. What that tells me is you're more on the lower end of the population versus the higher end. But it's a problem if you're 4 foot 10 and the next time you show up, you're 3 foot 10, then we have a problem. And likewise, if you're 6 foot 10 now, and the next time you're 7 foot 10, we also have a problem. So it's a change over time. And how the rest of your results look like, that kind of help us to kind of think about how to interpret your pressure number. The visit to visit fluctuation, often most glaucoma specialists don't get alarmed by that. So that helps, but that doesn't, it rarely sways our opinion about treat versus not treat, or if we do treat, what to treat. Those are more nuanced than simply looking at a number. So most glaucoma specialists now we use what's called a target IOP. It's a number that we use based mostly on personal experience and clinical trials uh, typically we aim for 30% lower than your highest recorded eye pressure as the target. And if your visual field and your optic nerve scan continue to trend downward, we may need to lower that more. And that is not something you can just tell right away. That takes time because this is, again, change over time. And changes in glaucoma often don't occur in just a span of a few weeks to months. It can be many years. So the higher the time frame, the easier it is to spot the trend. So how is glaucoma treated? It's a very much a ladder approach. We often start with topical medication, meaning eye drops. They're generally up to about 4 or 5 different medications. Some of them have what's called combination medications. They're one single eye drop bottle that may contain two different medications. If your doctor decide to prescribe you certain ones that are combination based, you may not be able to get it during because of some insurance issues. So there are always these external constraints on what you can and cannot get. But for the most part, most eye doctors will start out with something like latanoprost or Xalatan, which is only once a day at nighttime. It's also the same medication that a lot of the women are taking for lengthening their eyelashes. So that's a very common. In fact, that eyelash lengthening was discovered as a side effect initially, uh, and then that glaucoma medication was then developed into a cosmetic product from its original status as a glaucoma medication. So there are many such stories in medicine where the medication was initially intended for one thing, and as a side effect, it got turned into something else. Another common example of that would be Viagra. It was initially used as a medication to drop the eye pressure, but then the studies participants, I think the clinical investigators are realizing that all the men start hiding their Viagra and not coming back. And they realize they do a little more digging. Oh, it's doing something more than just dropping dropping the blood pressure. So that's how things kind of sometimes develop in medicine. Now, uh, in addition to the eye drop, there's also a laser option. And the full name of the laser is called selective laser trabeculoplasty. It has its role, and I won't go into the detail on when it's a good time to do laser. A lot of that is also provider based. People are trained in different institutions by different mentors, so that also has an impact. And also, um, some insurance prefers the laser to be done first, and some don't reimburse that. So it's a little more complicated than what is right versus what is not right. They're all right. Some people like to start with the medication first, some people do the laser first, vice versa. But almost everyone knows and agrees that surgeries are for something later. That's because surgeries are not curative. Surgeries are there when the first two things don't work or they're not enough to lower the pressure. Then we consider surgeries. Cataract surgery is considered a form of glaucoma surgeries too, because by doing the cataract surgery, we often can reduce the pressure by about 2 to 3 millimeter of mercury. There are also a huge number of what's called minimally invasive glaucoma surgeries, and there are many. A lot of those companies are actually based locally. And so I won't focus on any particular one of them, but they are often done in combination with cataract surgery because many of them are approved only to be done approved by Medicare, only to be done at the time of cataract surgery. Now, I like you to think of minimally invasive glaucoma surgeries and traditional glaucoma surgeries just like investment, financial investment. The lower the risk, the lower the return. The higher the risk, the higher the return. Kind of easy to see that, right? So the same parallel holds here. When it says minimally invasive glaucoma surgeries, there oftentimes glaucoma surgeons joke that there are also minimally effective glaucoma surgeries because when they're minimally invasive, they're oftentimes minimally effective. Doesn't mean that they won't work. It's just that you cannot count on these procedures to drop the pressure by 20 or 30 millimeter of mercury. They can help a little bit, but not a whole lot. While traditional glaucoma surgeries like trabeculectomy or tube shunts here, they can drop the pressure a lot more, but at the risk of more perioperative and postoperative risk. Here's an example of trabeculectomy. So what this surgery is all about is essentially the surgeon carves a little drainage window out of the white part of the eye so that because of the too much pressure and fluid buildup inside of the eye, that fluid is going to kind of leave that window flap to go under the superficial layer of the white part of the eye. So if you look at those people that have had trabeculectomy, they have these little what's called bleb, which is this fluid-filled space on the white part of the eye. You can look at the lower left picture there. If you look closely, there is a tiny little elevations of fluid. That's where all the kind of fluid in the eye kind of drains to. So there are various ways to do that. This surgery has been around since World War II, maybe even earlier. It's a very manually intensive surgery. This surgery often requires the patient to return to the clinic every single week because there are modifications that we may need to do, such as just restricting the flow a little more or opening up the window a little more just to get the fluid outflow in a good zone. Another common glaucoma, traditional glaucoma surgery we do is called the tube shunt. And this is basically a device where uh, it looks like a computer mouse with the wire part being a tube. That tube actually goes into the front chamber of the eye to help shunt the fluid in the eye out of the eye. So you can see on the right picture here, there's a little blue arrow indicating the flow of the fluid to go behind the eyeball where the eye muscle sits. And on the right lower picture, it shows you relative to the size of a US penny, you get an idea of how big or how small these tube shunts are. And you cannot see them even if you have it because they're hidden pretty much behind the eyelid. So in order to really see the edge of it, somebody has to you have to look down and have somebody else look into the top part of the eye, then they can kind of make out the sort of the contour of this tube shunt. And trabectome is one of the many minimally invasive glaucoma surgeries that we do. Trabectome was actually invented and developed here at UC Irvine as one of the earliest minimally invasive glaucoma surgery design in the world. So we still do a lot of those. It is an electrocautery device that goes to the corner of the eye where the drainage system sits and use electrocautery to remove that meshwork. So it's almost like just cleaning up the angle of the eye so that it's able to drain more fluid out. That's one way to kind of conceptualize it. So here's a question I kind of alluded to earlier. My doctor said my glaucoma is stable, but why is my vision declining? So um, glaucoma rarely causes noticeable vision changes. And so while you think that glaucoma is stable, but your vision is declining, you got to make sure that these other things are not causing an issue. And these common things are dry eyes, cataract, retinal problem, corneal problem. Remember, your eyeball is basically like a camera. So saying that your glaucoma is stable is like saying that that's imagine for a moment the eyeball is more like the old school camera in the 1990s. And glaucoma is more like the motor in the back that kind of advances your film and saying that that motor is working fine. So, and you know very well that just because the motor that kind of rolls your film forward is working fine doesn't mean that your camera is going to continue to produce excellent pictures because it's only part of the process. You need to have that motor that advances the film when you click the shutter, but that's not the only thing that's necessary for the whole thing to work, right? The lens has to be right. The lens has to be free from scratch. The film itself has to be a good quality, not overexposed, not got water droplet on there or something. The list goes on. So oftentimes it's worthy to look at these other places. And when a doctor often says that you look fine, I want you to think that the doctor is saying that he or she is not spotting anything that needs a treatment or that any particular treatment can make you better. Your eyeball may actually already be working at its maximum capable capacity. You got to remember, as we get more birthdays, your eyes are just like any other organs. They don't excel in function. They often don't gain function. If anything, not losing function itself is already a blessing. So, in order to keep up with what you used to see, sometimes you had to step back, like, wait, is it like a very noticeable gradual drop in vision? Or is this something that kind of fluctuates? It gets worse sometimes, but sometimes when I'm tired, I'm noticing more of these problems because it can very well be normal that your vision gets worse when you're tired. Think of your knees, for example. If you're 60 something, unless you're a professional runner, it's hard to be running just like you were able to when you're in your 20s. I'm in my mid 40s. I already noticed a dramatic, drop in my exercise capacity compared to what I was able to do in my younger days. There's always something that's already kind of physiologic. So when the doctor says glaucoma is fine, that doesn't imply everything else is fine. And perhaps if there's something that jumps out, for example, a retinal detachment, if your doctor sees that, they'll definitely tell you, oh my God, you have a detached retina, then let's do something. But short of anything that's a big issue or a red flag, oftentimes the doctor will say, yeah, everything is looking fine. It doesn't mean that you'll see 20/20 vision. It just means that your eyeballs are kind of working at their maximum capacity and we don't see any need to do something. So that's kind of how I want you to think of that statement. Now, I think I talked about that point. Let's go to the next question. We're kind of towards the end here. So what about supplements? So there's some early data coming out saying directly really linking leafy green colorful fruits and vegetables are really good for your eyes. And that shouldn't come as a surprise to people. Whatever, we all know what healthy diets look like. It's the problem is to stick to it, right? Because for many people, these fruits and vegetables, let's face it, they're not the most tasty and satisfying food to eat. Uh, but unfortunately, they are consistently being shown to help with your heart, help with your blood vessels. Given that your blood vessels flow everywhere, that means the benefits do spread everywhere in the body. It's good for your kidneys, good for your gut, good for your brain, so on and so forth. Now, outside of that, there are also some uh, benefits for the vitamin B6 and the B12. But I say that with a big asterisk. That's if you're lacking on the vitamin B12 and B6. If you're not lacking these vitamins, there's really no empirical evidence to suggest that you need to be taking these supplements. And the people who lack these vitamins often are like the strict vegans because vitamin B6 and 12 they're kind of you do get that primarily from meat source. But if you take tofu, even that probably will be enough. I mean, when in doubt, it's you can get your vitamin B level checked, but that's not a very common thing. I mean, in the course of my career, I've probably seen fewer than 10 vitamin B6 or B12 deficient patients that upon replenishment, somehow things just improve. So very, very rare, but possible. And I also want to just emphasize how much having a healthy mindset, healthy living, optimistic kind of mindsets can really just magically transform your body. I have seen a lot of patients in my clinic who are way over 90s, and yet they look healthier than some of the teenagers that I'm seeing. And I often can't help myself by asking them what are the secrets. So I've been having this hobby of just asking patients, what do you do? What is it that you do? And I've been getting very consistent answers from these uh, senior members. They all say they're all very appreciative of what they have. So, and they don't compare themselves against others. They don't come in here and say, well, my neighbor sees better than me. What's up with that? But they say, I am just grateful that I can see. Every morning I wake up, I feel grateful. It's another day. They have this mindset of focusing exclusively on what they have rather than what they have not. And when I first heard it, I mean, yeah, yeah, it makes sense. But when many of them start telling me the same thing, I'm like, wow, this really speaks to the power of just having a powerful mindset. Because when you set your mind right, instead of worrying about what could go wrong, and have that very high anxiety state constantly just affecting how your brain works, you're more relaxed, you're more just appreciative. That can have, I believe, profound impact on the rest of the body because your mind directs where your body wants to act. So it all starts here. So that definitely, if you do want to kind of work on something, this is something that we all benefit from just, practice every day. And there are also scientific and clinical papers showing that yoga, meditations, consistently, the data is actually quite strong, have almost the same effect on the eye pressure as taking one medication. So these are some of the data coming out of India where, it's not just doing meditation or doing yoga, you have to do it the right way. So you can check out on those paper on PubMed. Those are very interesting to look, but it's not just one or two papers. There are quite a few, and they all agree on the positive impacts of just having healthy mind and healthy living. Now, am I going to be blind? I would just say, while it is possible to go blind from glaucoma, the odds are extremely low, lower, significantly lower than the odds of dying in a motor vehicle accident. So simple answer is no, you're not going to go blind. As long as you are complying with your medication, show up to your follow-up regularly, the chance of that happening is effectively zero. So what happens in the rare cases where people do go blind? Um, I would say that the eye pressure is not the only cause of glaucoma. That's always possible, but that's very rare. Sometimes surgeries, glaucoma surgeries, or other eye surgery all carry risks. And sometimes, in order to save the eye, we have to lower the pressure. But unfortunately, by doing so, we set up other chain of events that ultimately lead to the eye losing a lot more vision than we first uh, before we started all the treatment. That's always a tough spot, all right? But we do know that by doing nothing, if your eye pressure is really high, and yet because of the surgical risk, sometimes we've seen patients like that, they don't want any surgeries done, then we know for sure you're gonna go blind. It's just a matter of time because having a high eye pressure, the chance of you going blind untreated, it's approaching 90 or 99%. We just don't know when. Nobody can tell you when because it also depends on how high the pressure is and how long you're talking about. If 3 months of pressure of 40, you will go blind for sure. But what about 28? Then nobody can tell because everybody's eye is different, but we just know that that eventuality is going to happen. So, but sometimes surgery had its own risk, so that can happen sometimes where more and more surgical complications happen. But I wouldn't let that be the deal breaker of not doing any surgery at all, especially when early on, the odds of success is still higher than the odds of complications. Late diagnosis, unfortunately, if you have had glaucoma for a very long time, that also implies your nerve has been quite damaged to begin with. And once the nerve has been damaged, it becomes harder to kind of keep it at its current state. You know, think of your kitchen dining table with one of the leg already kind of buckle a little bit. Then it doesn't take much more additional weight for that table to just completely collapse. It's because whatever is left over has to pick up all the extra slack. So it's going to have to consume more oxygen and it's going to consume more nutrients, causing the current damage to become even more manifested. So that process is unfortunately it's like a negative cycle. So you do want to kind of intervene early if possible. Finally, juvenile or childhood glaucoma. I would just say that if you had juvenile or childhood glaucoma, the odds of losing vision over a lifetime is quite significantly higher because they're kind of a different entity, very different from the classic Medicare age glaucoma. Uh, in fact, many juvenile or congenital glaucoma patients, they go blind before they even reach adulthood. So that's almost a very separate entity, which I won't elaborate on too much for this audience. So finally, what is coming in the horizon? Uh, Several companies are now working on sustained drug delivery, whether it is intraocular, meaning being coupled with an intraocular lens so that at the time of cataract surgery, that you get like a reservoir of medication to be released from your lens. That's one idea. That company is pretty local and still working on, I think, phase two trial, if I'm correct. Contact lens has long been thought of as a perfect medium to deliver medication, but it's not as easy as one thinks. Even big companies like Google has tried to tackle this challenge, and Google, I think, just recently restarted that project after kind of putting that project on hold for almost 10 years. So it's interesting when Google jumps in, then other companies may jump in to kind of attract each other to work on this problem. Punctal plugs, some of you may have had punctal plugs placed on your tear drainage duct to improve surface moisture. That plug can also be uh, impregnated with drug molecules, and that's a way to deliver drug. So there are several clinical trials going on right now that'll be interesting because that's easy to place, and then that can potentially um, get rid of the need to keep doing eye drops on a daily basis. Of course, there will be new classes of glaucoma medications coming out. My best estimate will be probably within the next 2 years, there will be two more completely different mechanism-based glaucoma medications. Uh, I don't always look at these as you know the Hail Mary event because when a new medication comes out, the cost is often very high, and also their side effects are something that takes time to completely figure out. So while they may work with a novel mechanism, no drug is without side effects. So we kind of have to temper that excitement with a bit of realism as well. And also, there will be glaucoma drainage implant with improved design and improved biomaterial, which translate into a smaller implant, but being able to function just as effectively. Stem cell, optic nerve regeneration. Locally, we have UCI investigators that are working on that, using stem cells to try to repair damaged optic nerve, or even more ambitiously, to regenerate a whole segment of optic nerve. We can do that. That will be fabulous. Finally, brain-computer interface. That is something that's actually um, wasn't even around when I last gave this talk about 2 years ago. This is something new. This will completely bypass the eyeball and stimulate the brain directly. The visual part of the brain sits in the back part of the brain in this part of the brain called the occipital lobe. That's why if you take a baseball bat and hit somebody in the back of the head, you can actually cause blindness because then you can potentially damage that part of the brain that's responsible for vision. But because of where it sits, actually makes it relatively easy to use brain-computer interface to talk and connect to an external camera to restore vision. Now, there are several companies, among them is Neuralink, which is started by Elon Musk, that has done quite a bit of these nerve or thought actuator, meaning you just need to think about something and then the computer can do that. And so the reverse of that will be to interpret what the camera is seeing and feed that information back to the brain. That is not science fiction at this point. The company is quite secretive on what they're doing, but they are running clinical trials and I think the UAE and several countries outside of the US. Still too early to tell, but I think the momentum is strong. The scientific basis is quite strong too. It's something that definitely for those of you who are interested, you can read more about it. So that's it. Thank you for staying with me to the end.